Welcome, everyone. Thank you for joining us today. Welcome to this month's webinar, Movement Disorders, the Basics of Diagnosis and Treatment, presented by Dr. Jeff Brown and moderated by Dr. Rebecca Lauk. Please consider joining us for next month's webinar on January 13th, Why Most Practice Advertising Fails, a step-by-step guide in building a successful marketing plan. It should be super interesting and really help run a practice. You can also look for more educational opportunities on our Facebook, our YouTube, or our Twitter. We are excited to be offering a specialty injection series, a series of 2-day courses, the first of which is offered in Dallas-Fort Worth on January 22nd and 23rd, the second of which is in South Bend, Indiana, February 19th and 20th. Registration will be opening up after hours on Friday. Make sure to check your inboxes that following Monday for information how to register. It is limited to only 15 participants per area, so make sure to sign up early. Go ahead and introduce our moderator, Dr. Rebecca Lauk. Dr. Rebecca Lauk attended Austin College in Sherman, Texas for her Bachelor of Arts degree in Psychology and Sociology. She followed through on a lifelong interest in pursuing dentistry as a career at Baylor College of Dentistry in Dallas, Texas, earning her doctorate in dental surgery. Practicing general dentistry for more than 34 years, Dr. Lauk has taken many CE courses and established herself as an expert in all phases of dentistry. Her focus is on the oral cavity. TMD, orthodontics, and sleep are all connected to the oral cavity and influence each other. Dr. Lauk has a special training in all of these areas, in addition to holistic dentistry and cosmetic dentistry. Welcome, Dr. Lauk. If you would do us the honor of introducing our presenter, Dr. Jeff Brown.
My pleasure. Tonight we're going to be hearing from Dr. Brown. He focuses on TMD, sleep apnea, and orthodontics. This allows Dr. Brown and his team to provide individualized, focused care for patients dealing with these specific issues. Every day, sleep apnea and TMD help patients of all ages with facial development, sleep issues, chronic headaches, migraines, neck pain, movement disorders, and much more. His training also includes multiple disciplines involving the cranial bones in the skull and the discs in the jaw joints. Through treatment, Dr. Brown is able to reduce these symptoms, align cranial bones, avoid extractions, and greatly reduce the need for traditional braces. His expertise allows him to identify issues early on, which promotes proper facial development using dental appliances. He earned his degree from Georgetown Dental School and completed residencies with Emory University Hospital for dental sleep medicine and the ALF Appliance Therapy Institute. When not seeing patients, Dr. Brown is sought-after speaker. He has lectured all over the world, including DC, Dubai, Seoul, London, Norway, and Toronto. He has also been featured on Channel 9's Good Morning Washington, several podcasts, numerous magazines, and journals. He is a member of the American Academy of Craniofacial Pain, the American Academy of Dental Sleep Medicine, American Academy of Gnathological Orthopedics, Academy of Integrative Pain Management, and the American Dental Association. It gives me great pleasure to introduce Dr. Jeff Brown this evening.
Now, basically, my story is I was rear-ended 25 years ago, made my first appliance with a splint because of Dr. Stack's courses. Took over Brendan Stack's practice a number of years ago. Brendan stayed on, thank goodness, for a number of years, really kind of pushed me into different areas. And let's get into the whole thing here. What people have been asking for is they would like to understand a bit more about TMJ and the correlation with movement disorders. And basically, there's a couple of tools that we use to help understand, but I first want to go through some of the reasoning of what we're doing here. The TM joint really is one of the most complex joints in the whole body. On top of the condyle is this little thing called the articular disc. When that articular disc is out of place, and oh man, it's out of place on so many people, it wreaks havoc with the entire body. I was down in New Orleans last year lecturing, and a nice gentleman named Don Brown, he had done these wonderful articles, which I'm glad to share with folks if you would like, but it's all about how TMD affects the entire body, and it's just an amazing bit of research. So back to what I'm looking for is the disc riding along the top of the condyle. And if that little disc is not riding on top of the condyle, it's not healthy. If it's slipped off, it's not healthy. Now, here's what the disc looks like in general. This is the condyle. All right, so this is the normal disc that we see here. I'll put my cursor to it. The disc should be at the 11 o'clock or 1 o'clock position, depending on orientation. So what is TMD? When that little disc has slipped off. When the patient bites down, the disc slips off the top of the condyle. Then you end up pinching all the blood vessels, nerves, the tissue up in here, and you just so happen to have ear problems. I see countless patients with tinnitus, hissing and buzzing in the ears and all that. So anterior displacement is the most common. The disc is slipped forward of the condyle. Lateral displacement, where it's slipped to the outside of the skull. Medial is the worst one. Now, the interesting thing with medial displacement is that in almost every Tourette's patient, I find medially displaced discs. And that is the norm these days, and I don't know why. So here is the joint video, or the yoint video, we used to call it, but I show this to patients who aren't grossed out. And when that disc slips, like that is anterior displacement. That's the snapping and clicking that you get. And there it is snapped out. Let's see. There it is, just riding along nicely in the fossa. That's what we want to see. And then I'm not sure if we'll get this snapping out of there, but nope, we're going to go forward then. Okay, anterior disc displacement. That little disc is right here where it should be. And when you open, it pops out of the socket. Now, this is anterior displacement happening. This is where the disc ought to be. This is this tissue right here. And this is why you have to do an MRI to make sure you know what you're dealing with. So the disc is going to snap forward. There's the click. It snapped forward. And now it went back on top of the condyle. There's the click or the pop that you'll frequently hear. Now, unfortunately, what happens is that this will cause damage to the condyle over time. And in this one, you actually can see the pitting and the breakdown from all the stress. Now, here's the MRI that we run, and I think this is an important aspect of the diagnosis. This was one of my movement disorder patients. The articular disc is medially displaced or on the inside of that condyle. And here you see the blood vessels and nerves, all the dark spots. Those are blood vessels, those are nerves, all being pinched by a slipped disc. So you can get movement disorders, you can get pain, all sorts of symptoms will occur when that disc is slipped. Now here's the bane of my existence. There's the medially slipped disc. That disc dropped in to the inside of the condyle. It did come back up, it reduced, and that dropped back inside. Now this is what we call lateral displacement. Again, pinched nerves, pain, inflammation. Again, the little dark areas, blood vessels, nerves, all sorts of stuff being pinched from a slipped disc. That disc should go from basically here out to here. You can also see the pitting of the condyle. That tells you that this has been like this for a long time. This is something that happens over the course of time. The disc slips, you get erosion. Eventually, that disc is perforated and torn, and this is what it looks like when it's been removed surgically. There's actually a hole inside there. And unfortunately, we see too many of those. Okay, so where are the nerves? They're literally all over the place. There's nerves, there's blood vessels, there's muscles all over. The interesting thing I'm getting a lot more of these days is the tinnitus issues, because when that disc is slipped anteriorly, as you function, I'm finding the condyle pushes back towards the ear canal, causing all sorts of issues. I don't need to read about muscles because you all know that. And I'm not going to waste your time going through a lot of this. This is really clear that you can pull it up on Google and look at all this stuff. But the bottom line is, for example, a lot of patients come to me, they've been diagnosed with trigeminal neuralgia. And I would like to find out why there's a diagnosis of trigeminal neuralgia. And what actually is going on most of the time, the disc is simply pinching either the ophthalmic, maxillary, or the mandibular division. and therefore a pinched nerve hurts. I'm kind of a simplistic kind of guy. Pinched nerves hurt, and that's just the way it is. And the analogy I use is, hey, if your doctor said you've got a pinched nerve in your lower back, that's why your legs are numb, your back hurts. Real simple stuff. Now, this is more interesting. The glossopharyngeal nerve shoots down to the gut from the TM joint area. Is there a correlation here? Someone might be thinking GERD, gastroesophageal reflux disorder, how it ties in with sleep. So if the airway is collapsed, the vertical is collapsed, the disc is collapsing into the glossopharyngeal nerve, maybe that ties into stomach problems. So another thing to be looking at. So let's get into movement disorders. We have found that by treating the TM joint, we're dealing with things like Tourette's, Parkinson's. Parkinson's, I think, is Tourette's for older people. A lot of our patients come to us with essential tremors, i.e., the hand is shaking, the arm is trembling, head pain, neck pain, migraines. Our goal is to try to get that articular disc back on top of the condyle where it belongs. And as you folks can see, with that young lady, one of the things that some of the people say is you created a neurocranial vertical distractor. Well, I don't think so. I think we took the pressure off the articular discs because the cases we see, this is a listing of everybody we see. Just the other day, I had a nice lady in with dystonia. Her whole head is literally hanging off the side, and her husband comes in with her blinking his eyes like crazy. That's what you call blepharospasm. So we already know he has a TMJ disorder. He doesn't want to recognize it because men are not very smart. And that's just the way it is. Gail came to me a few years back, muscle twitching, throat pain, shoulder pain, jaws were clicking like crazy, breathing issues, and as you can see, severe dystonia. She had suffered from this for 20 plus years. She flew up from Melbourne, Florida. So in the right joint, there's anterior displacement. And the left, we could not see because her head would not get straight enough to visualize. Or we do know the discs were out of place a bit. All I did with Gail was I put in a mandibular hard acrylic splint. The reason for that is it just took the pressure off the articular discs. Now, just like Dr. Stack did, I'm showing my best cases, of course. It's not like this every time, folks. Don't even begin to expect this, please. It's just that Gail responded instantly. And this was like, I think 7 years ago. To this day, unfortunately, she is still wearing that darn splint. She flies up when she can. It's just too much money for her to keep up with it. And I actually don't even really charge her for my visits. I just want to try to help her out when she flies up. Okay, now the next one is Jessica. She comes down from Maine. And this is with a lady that I met. Now with the sticks, but this is another very good example. This is the lady, she suffered for, I don't know, 15 years or so. And the poor lady was just in such bad shape that we did the stick test on her. This is what happened. Now let's go to the other one. This is her once again. You see the pulling on the shoulders, the pulling on the neck, all very classic signs of dystonia. And the pain has just been tremendous. Okay, now here is Jessica over at my office. And you can see the distress that she's in. She's trying to control it very admirably. My team is working on her appliance. We'll pick her up and we'll fit this guy in place. Now watch the chest. There you go. That's what we typically see when we do these things right. The immediate relief occurs. And again, Jessica is wearing her appliance, and the tremors in the hands are gone too. So, another good example of the people that we meet. God, look how sloppy that guy is right there. The wrinkles in his shirt, my goodness. Anyway, her comments came in later on, feeling better. She had a rough couple of days with the adjustment, but very positive changes. How we do it? How do we diagnose? First thing first, folks. My new patient sits in a bar stool across from me, and I have them stare at my nose. Then I just look at them. They kind of smirk a little bit, thinking, this guy's a little Looney Tunes. Well, yeah, I am, I guess. But ultimately, I'm looking at the distortions that are obvious. Are the ears level? 99% of the time they're not. Are the eyes level? Usually not. Eyebrows? Is the head cocked to one side? Is the cervical spine even? So all this is part of my just initial observations. In addition, my team members, they do pH, blood pressure, pulse, and BMI and a neck circumference measurement as well. Then I walk in. Take a look at this nice young lady here. I hear she's a Hollywood type, but if she sat in my chair, I'd say, ma'am, your left eyebrow and left eye are quite a bit higher than the other side. And because of that, she has intracranial distortions. This lady is some kind of movie star. I don't know who she is. This guy's another movie star. So is the other fella. Look at the imbalances on these fellows. They're out of whack substantially. So look at the sclera of his eye, the white, very much off. Left ear out, protrusive. So I know the mastoid bone is rotated out on this guy. So all these folks are very famous people. This one doesn't sleep. You can see it in her eyes. This is unfortunately that guy who killed a bunch of people in the airplane a few years ago. Look at the jaw on this person, the eyes, the ears. The jaw is fairly level here, but the lower jaw is canted this way. So this is where it all begins. Little Johnny looks kind of cute with all his distortions here and there. His eyes are not even. I tell all my new patients, the moment you have that baby, take the little one to an osteopath doctor and get the cranial bones, the TM joints lined up. They can be lined up quite nicely at this age. That's when it all should be done. So look for causes. So as the dentist, if you're all pulling teeth on people right and left, what's going to happen is that you will collapse the condyle into the fossa and cause disc impingements. Look for hyperlaxity. That means EDS, Ehlers-Danlos syndrome, that type of thing. I recently invented a new version of an EDS patient specifically. That would be a whole other hour discussion. So you want to look at the, okay, let's bring up this issue, past orthodontic work. I have a big problem with how orthodontic work is being done in this country right now. Currently, teeth are made straight to look good on the maxilla and on the mandible. The z-axis, the vertical height, is most often ignored. And because of that, we're getting impingement upon the articular disc. Accident cases, these things happen all the time. Injuries, tooth extraction, birth trauma, all these things are factors that cause temporomandibular disorder and slippage of the articular discs. So you have to get into the history with these patients. This is a stock photo of all the things that you want to look for when you're dealing with TMJ patient. All right, so here's what I'm talking about. That patient, he is sitting in front of me. If you look at him, look how the right ear, right eye, eyebrow are very significantly distorted. He just doesn't look good, folks. So I note all that. Range of motion. When the patient opens as best they can without hurting, the tip of the upper teeth to the tip of the lower teeth, that should be 50 to 54 millimeters, not 40 millimeters. I'm sorry, folks, 40 is not a healthy zone. There needs to be a little spring in that too. Then I palpate for popping, clicking. Most of the time, I order an MRI. Now, this is very interesting. It has been quite controversial. I've dealt with a whole bunch of doctors all over the US on this. My MRI is open and closed, left and right TM joints, high field, wide bore, at minimum 1.5 Tesla is what it's called with no contrast. Recently, I added hemorrhagic anomalies, meaning let's look at brain bleeds, concussions from the past. Then recently added in condylar angulation. I want to know if the condyles are referencing to each other. Are they going along the same axis, like the front end alignment on your car? Are the wheels tracking straight and true, or are they going against each other, pulling one side or the other? That will cause some serious issues with the TM joints and further the dystonia effect. So this is why we do the MRI, looking for internal derangements, abnormalities. And here we go with this is the condyle. This is about what it should look like. But look at this condyle thinned out. There's a slip disc. There's the articular disc. It is way out of place. Should be up at 11 o'clock. So that is down here. It pushes the condyle back, and that condyle is slowly eroding away. But don't count on the MRI for everything. I'm going to try to go through this fairly fast. This is the articular disc right here, folks, that bow tie. That's where it should be upon normal functioning. Look how close we're getting to the ear canal. Laterally slipped disc, very, very prominent, very obvious. Medial. Again, pinching blood vessels all through here. Medial displacement, most of the time, Tourette's. Anterior slippage. Again, normal disc is this bow tie right here. Anterior is down in here, and there may be a little crumpling there. Now, this is one thing I really like looking at on my MRI. Are the condyles in the same field of view? Are they level? If not, we got a big problem, folks. Look at this. The top of the left condyle, I don't even see the right one over here. So you know there's a cranial bone distortion on this patient. Okay, left joint, slip disc. Here is osteoarthritis, i.e. breakdown from the disc being so inflamed for so many years. The chemicals of inflammation get in there, bradykinin and stuff like that gets in there and starts eroding away the condyle. That's what it looks like on the actual MRI. We're looking for imbalances. Left condyle higher than the right condyle. So in that plane of existence, we're out of place. Medial slippage. Anterior displacement. Again, I'm going to whip through these real fast. Lateral. And again, medial. Now, no lamina dura space. So here I am looking at no space right there. A little bit of lamina dura here, but you know that the condyle is too far up in the socket. Inflammation, swelling all through here. And there's some very distinct degeneration of the condyle. Unfortunately, I see way too much of this. And this helps you decide on the type of appliance. Condylar degeneration. I'm going to skip through. That's a perforated disc there. Imaging that is required in my office. Panoramic, lateral sepsis, PA skull. That's how we used to do it. Now I'm using the VaTech green machine for 3D CBCT. It's fantastic. We're getting volumetrics of the airway. I wish I had time. I'd show you some fantastic shots of increasing airway volumes. But we're going to move through this. Panoramic is just simply the overview, looking at wisdom teeth, imbalances. Okay, here's a collapsed bite through here. 2 missing teeth here, a couple over here. Then, see, folks, can you see the stylohyoid calcification through here and substantially through here? These are very, very large calcifications of the stylohyoid ligament. It goes from the styloid process behind the ear at the mastoid area down to the hyoid in your neck. And when these things calcify this big, think of Eagles syndrome. Eagles syndrome means it's very difficult to swallow. Well, yeah, you've got this whole darn bone in your neck putting pressure on your throat. So on this one, left condyle degeneration. This person had the 4 on the floor. 4 bicuspids extracted, 4 wisdom teeth out. That's 25% loss of teeth. Vertical collapse occurred, jamming the condyles into the socket. Now this one's even more interesting. Deviated septum, the sinuses are imbalanced, decay in the upper left crown because the bite is all off through here. Look where the right condyle is relative to the left. That's totally out of place. And this is what happens to me almost every day. Lateral sep, another important one. Now, you must do a lateral sep for this reason, if this is the only reason. That is called a ponticulus posticus, folks. Look it up. Ponticulus posticus. The vertebral artery snakes through here, going to the brain. Let's say you say to your patient, I'm going to send you to the chiropractor, and Joe, the chiropractor, snaps that neck. If he breaks that, that will impinge on the vertebral artery, and that'll be that patient's last day on this planet. Also, you want to look at the C-spine. We actually have a kyphosis here, a reverse curvature. So this person totally needs physical therapy, osteopathy, whatever you all want to do, but make very aware to the PT or osteo that there's a ponticulus there that is dangerous. Okay, again, kyphosis, loss of curvature, steep mandibular angle, things to look at. Again, kyphosis, lack of lordosis, and this is real funky through here. Again, I see this every day of the week. So frontal skull is the next one. Again, going fast through. This is a dystonia patient. You see how the neck is clearly pulled? And we lined up the skull all right, but even when the skull is lined up, the right mastoid is higher than the left mastoid. Things are all out of whack. And this guy too, look where his cervical spine is over here. Neck pulling all through here, very typical. Okay, the condyle should be in the Galb 4-7 position, roughly there, roughly. Treatment ways. Okay, clearly we have to decompress the TM joints. This helps to open the airway, relaxing cranial nerves. The body will help align too. Leveling the jaws over time, reducing inflammation. Now, this is another contentious point I get. All over the country, I've seen the practitioners doing this. They tell the patient, wear this all night long. Well, that's incorrect because the discs are slipped all day and all night. Now, the other issue is it needs to be flat because if you don't have a flat appliance on the mandible, you will not be able to release the medial or laterally slipped disc. That's a key important point here. So if you put a bite to this thing, you're maintaining the pathology, even though you're dealing with the Z-axis. So you must have a flat plane splint. Patient has to eat with it, sleep with it, talk with it, drink with it. Everything is with, otherwise it's not going to work. The modified Galb appliance. This is a pretty steep mandible, less steep, but notice the airway increased after wearing the Galb appliance. But also notice there's a posterior open bite. That's where the bite should be. Now, I don't know how to survey you folks, but I kind of hope a bunch of you are familiar with the ALF, the Advanced Light Wire Functional. Credit to Derek Nordstrom, absolutely brilliant individual who invented this thing. This is something, if you're not doing ALF, I could run a whole 5-day course on this stuff. You need to learn about this. This levels the cranial bones. It helps open up the joint space. It opens the airway. It widens the palate. Now, unlike a palatal expander, which I banned palatal expanders many years ago for the reasons that they don't deal with the three-dimensional aspects. They also block the tongue. They distalize the condyles. A lot of reasons I don't use them. The ALF is a very light wire device that is removed by the doctor. And now lately, I've had the patients remove them too. I like mine to be removable for good brushing and flossing. The University of Virginia Hospital has indeed confirmed we have a lymphatic system in our brain. My osteopath doctors have confirmed that if that drainage does not occur, that confirms that it leads to ADD, OCD, autoimmune disorders, and Alzheimer's as we age. And they've made the correlation many years ago, told me that, hey, Jeff, your ALF appliances promote lymphatic drainage in the brain. Don't have to believe me. Go to UVA, University of Virginia Hospital, and you'll get a confirmation that that's how it works. ALF appliance, this is what it does. This is a deviated septum. Spinous processes in the neck are over here on his left center. A year later, spinous processes are aligned. There's the ALF. No more deviated septum, non-surgically done, folks. The palate is now balanced, but previously, look at the bone turned into his palate. ALF Gelb. This is the most common. This is Matt. Matt has Tourette's. He shakes all over. He has a lot of OCD, ADD issues. He does not sleep very well whatsoever. Opening 50 millimeters, that's within normal, not bad. Possible medial or lateral displacement. This means there is some displacement, but it's not clear. There was probably movement when they did the MRI. And that's what he looked like. Always think three-dimensional, please. Look at this 100% deep bite. Clear sign that he is pounding the articular discs with the condyles. Teeth are being jammed up hard. Cranially, he doesn't look all that bad, folks. But from a side view, yeah, there's a lot of distortion there. So I made a modified Gelb. It strikes the lingual cusp of the upper sixes, the upper 6-year molars. That allows, oh yeah, the different height on each side, really important. Notice how this side is much shorter than this, but the midlines, the frenums are correct. So what you do, you pull the upper lip up, lower lip down, make sure the frenums are the right way. So by making the platform taller on his right, that'll push the midline towards his left, more in center alignment. And notice the cant of the upper jaw. That's all out of whack too. Okay, he has his appliance in place. Now he's taking it out. And just give him a second. That's what he starts doing almost immediately. So now Matt has the stick test going on where we put the sticks in, he bites down, holds them in place. And this is not a perfect test. We'll get through this real quick. So without the sticks, see what's happening with Matt. Oh, this is now, I want to take a moment to introduce Joe. Joe flew up from Orlando to come see me. 25 years she has suffered with dystonia. This lady, super, super nice lady. All these people, by the way, gave permission for me to use their photos in their cases. Joe came to see me, 25 years of suffering. She went to work every day at an insurance company. And every day she went to bed at 5 p.m. It hurt so bad she couldn't function, couldn't sleep. Eye blinking was horrendous when I met her, fatigue. And then her husband left her with 2 children all by herself. Pain is the red zone. We have the patient mark that off. Palpation exam. I don't need to read all this, but everything hurt on this lady. Everything I palpated. See the unevenness of the condyles. And that's the lady that we met. So before treatment, look at the midline here, folks. That's the maxillary midline, mandibular midline. We are way the heck off on this. So we did a modified Gelb appliance, the lower hard acrylic, and we started working the midline. It's not quite there yet. It's going to take time. The ALF, the process of leveling cranial bones, which transfers throughout the entire body, improving cerebral spinal fluid flow, lymphatic drainage. Okay, the bite with the midline centered. Now, she unfortunately had braces as a kid. They dragged her teeth around, but from a midline frenum viewpoint, she's lined up correctly. And another one, 15 minutes after we put this in, she lined up almost right away. And this was years ago, 5 years now. She's still wearing the same darned appliance I made her. Again, economics. She's taking care of 2 little children who are older now. Money is a concern, flying back and forth. So I'm not even sure what she's doing. We do talk on Facebook frequently. She's doing okay. She really needs an adjustment, but hey, not bad 5 years later. So you can clearly see this person is sleeping. She's happier. The eyes look nice. This person was not a very happy camper. Joe came back for an adjustment. She cracked a chunk off the appliance. We adjusted it in the office. And a few minutes later, she's lined up a little bit better. And this is her now. She's actually dropped a tremendous amount of weight. And there's the person we met. There's the person 2 years after treatment started. Worst case, folks, sometimes you need surgery to fix this. Sometimes the discs are damaged beyond repair and have to be removed. I work with Eugene Gregory, a board-certified maxillofacial surgeon. He's operated on thousands of joints. He and Dr. Stack began the process. I've been just a lucky enough guy to continue with Dr. Gregory, and I feel very blessed. He's in my corner. But this is a whole other animal to deal with. Things known surgery. Every one of you is going to say in your mind, oh my God, don't do surgery. It's too dangerous. It doesn't work. No, not true. It does not work when done in the wrong hands. It does not work. When in the right hands, it works 94%. And that's the report that we have on this. You're welcome to it. So you must put an appliance in. You have to decompress the joint. You never dive into surgery right away. You always go with appliances first. Okay, you've got to get into case finishing. Jack is an interesting case. I met him, flew in from Chicago. His tics were so violent, he broke my dental chair. My 800-pound dental chair broke because he ticked so violently. Now, if you'll notice, yes, this is 15 millimeters from here to here. This is what Jack required not to tick violently. Anyway, this is Jack. That's the little bit of ticking that he does now. In case you can't hear, he sleeps better. He has no pain, really. Jack is somebody who had medial displacement in both joints. Again, I see it all the time with Tourette's. Now, he got better just with that appliance, but he ended up having surgery. What the surgeon found was the left, I believe it was the left joint, the disc was in pieces, in shards. All the MRI showed was medial displacement. The tics were so violent because for 20 some odd years, he had shards of disc tissue floating around up in his joints, irritating the nerves. There's the incision that Dr. Gregory does. A couple months post-surgery, that's 2 months after surgery, that's all that you see. So yeah, severe medial displacement. Disc was degenerated. So this is an important thing, and I think right on time here, folks, just about. You must work with your team. Absolutely. I work with myofunctional therapists. Tongue ties are not acceptable. That creates problems with breathing. Sometimes surgery is needed. Now, let me please point out something that might help. It's very important, I think, that when you have wisdom teeth out on a young person, they wear their ALF appliances to keep the arches stable, because every time you pull wisdom teeth, 4 teeth out, you'll have 16 square centimeters of bone loss, big holes, in other words. The ALF appliances, and like I said, I'd love to get into that more, the ALFs will keep the proper support for the cranial bones to avoid collapse. Prolotherapy, I don't use it very often, but when I do, it does help. OMT, osteopathic manipulation therapy, that's an important thing that it's worked out very, very well. Radiologists need a great MRI. And of course, you need the dentist because very, very often, many of our patients come to me, crown, root canal, implant. And all I have to do to finish their cases is have the dentist put a bunch of crowns on top to lift the teeth up. So it is definitively a team approach. Anyway, thanks for hanging out. I didn't mean to go a couple minutes over, but I hope this was helpful.
Thank you very much, Dr. Brown. If you all would, please give us some questions over in the chat box.
Yeah, I know sometimes this is a little controversial, to tell you the truth. And it's not in the realm of so many people. We don't know if it's a medical thing, a dental thing, or a combination thing. And I must admit, I learned a lot of this after many years of different educational levels and different programs I've been to. And my direction nowadays is down the path more towards osteopathy. When I hold a patient's skull, I can sense the blood flow, the pressure. I can feel the bowling ball effect of a heavy, heavy skull. And by learning how to alleviate the tension, people just feel better. But that's become my latest avenue of training and studies. And of course, airway.
I have one question here that asks why the flat plane splint rather than a dictated bite?
Okay, can you all see my fist, the condyle? There's the disc where it should be. If the disc is medially displaced, If you lock the bite, you're only locking that medial position. If you have a flat plane splint, the condyle can go out here in all directions. Now the medially slipped disc has a chance to come up on both sides. That's why flat. And granted, the patient hates the GD thing for 2 weeks. They're talking like this. They're like, how do I eat? Well, we give them a recipe book that we put together at my own office. Soft food. They have to be on soft food. And 90% of the time, within 2 weeks, they hate me for 2 weeks, and I can live with hatred. But within 2 weeks, they're feeling better. And they put up with this piece of junk in their mouth that they paid a lot of money for. They tolerate it, in other words. But yeah, it's got to be flat. You never index the splint. It's what Dr. Stack told me many years ago. Never index it until the bite and the disc until the disc is properly positioned. Then you index it because now you can lock it in.
How long do you leave it as that flat plane tall splint before you do weaning?
Okay, well, weaning is not the concept here. Let's be clear. The real problem is a collapsed occlusion. The condyles are literally jammed in the sockets because the bite is collapsed over time. Now they're jammed up. You wear the splint for a good year. Then we only wean you down to the front teeth touch. The back teeth won't touch. You have to either orthodontically lift those teeth up, grow them taller, erupt, or you cap them over to that height of the splint to protect the integrity of the joint space. But no, you don't wean them off. Now, I'll take that back a little bit. If that patient is 85 years old, they've worn the splint for a year, they're like, I want to have a steak at my age, I deserve it. I say, okay, have your steak, but then put the splint back in place to protect your joints. And then definitely wear it all night and as much as you can. At 85 years old, you deserve that.
Another question that was asked was, where do you get to learn these techniques? Where do you go?
Oh, well, I had Dr. Brendan Stack, the father of TMJ, teach me. I've been doing splints for many, many years. And along that note, please allow me, please avoid maxillary splints. They are not good. They're not healthy for the body for 3 reasons. Number one, when you bite on it, the jaw goes back. It distalizes the condyles, banging the discs. Number two, you cannot get your tongue to the roof of the mouth where it belongs, which reduces good nasal breathing. Number three, the internal rhythm, the brain is moving like this with blood and CSF pumping. And my osteopath doctors say a maxillary splint locks up that motion and slows it down. So for a developing young child, you put an upper splint, think RPE or something similar, you will slow down cranial motion. Not healthy way to go. That's why I do a mandibular splint. The ALF up top promotes and enhances the cranial rhythms. There's a method to the madness.
I have a question here on Prolotherapy. If you use it, do you inject in the anterior and posterior joint splint?
I don't use it myself. I refer to my osteo doctors. Honestly, I've got 20 patients a day. I'm too busy just doing appliance therapy. I'd like to get into it maybe one day, but Prolo or Botox, I only recommend it for severe trauma cases where all bets are off. I mean, if you've been in a car accident, you've been all smushed up and messed up, you're probably going to need something like that forever. The problem with Botox, the new research on it shows that at the injection site, the masseter, for example, the bone is losing its integrity due to the damage from the Botox. So, it's all trade-offs, Rebecca. You inject the Prolo, yeah, maybe they're going to feel better for a while, but Prolo is far more gentle than Botox. So Botox is definitely more damaging. But on the trauma cases that I have, the cervical spine, if they inject there, it atrophies the muscles so much. The patient has to go off of Botox, try to stimulate the muscles to regenerate. Then by the time you go back to Botox again, you'll start atrophying that muscle all over again. So I don't like it, but if a patient absolutely needs it for survival, I have no problem with it.
A couple of people have asked where you place or what teeth are used on that flat plane, the lingual of the first molars or all the molars?
No, lingual of the first molar. That's the pivot point. That allows for sliding around left, right, forward, sideways. And people are always saying, well, isn't that just going to cause your mandible to distalize? No, it doesn't. Mother Nature will normalize when given a free hand. In other words, you loosen everything up, Mother Nature will settle things in nicely. That's why the splint is designed that way. Now, the upper one called the ALF, and this is an analogy I just came up with, and I tell my new patients, I'm looking at you, and if you look at me, folks, my left ear is higher than my right. I have a vice grip on me doing this. So the ALF just simply does this. That's the analogy. People they understand that very well, it seems. But when you're cranially disoriented, like my glasses, when I was younger, I would take them off and they would be literally like this, bent, because my eyes were so far off. My canted jaw was a mess. This is an improved me using ALF appliances. I'll never be perfect, but I'm trying.
I have one person asking, do you always use an ALF with patients on a Galb, or how do you pick when you use that ALF?
If it's a younger patient, 99% of the time you must use an upper ALF because there are cranial bone distortions. You've got to try to normalize the distorted condyles and fosses, try to swing them around. If I was at my office, I could have looped in 30, 40 x-rays just from this year alone of how we've taken this to this. And you can see it on the C-spine. But if they're older, honestly, like this week already, I've had a couple of 80, 85-year-olds. All I do is the mandibular Galb splint to protect their condyles and their discs. And I tell them, look, if you were 25 years old, I would insist you wear the upper ALF as well. And a bunch of them say, well, I want to do that anyways because it's better. Well, I'm not going to force it upon them, but the appliance on the lower of the splint does well enough. And if they can't afford the upper ALF, then we just go with the lower splint. That's okay. It's good enough in some cases.
How do you determine the height that you place those splints at the Galb at?
Okay, you use the little sticks for a generalization. That's called the stick test. However, I always start my splints off very low to get compliance better. If you have a splint that is this high, compliance will be just about 0. You cannot go that high. So you put it in, maybe the anterior opening is like 2 millimeters. That's much easier for the patient to get used to. It's like Dr. Stack used to use his analogy saying, I'm going to start you off with tennis shoes. Eventually, I want you wearing high heel stilettos. And then as the months would go by, he would jack up that appliance. I've got one guy who's at 22 millimeters from edge to edge. Without it, he has severe grand mal seizures. His dentist looked at my appliance and said, who's the blanking idiot that made this? And the guy said, well, let me show you how stupid this guy Brown is. He took the appliance out, went into a full seizure, and the dentist was freaking out, said, put it back, put it back. So 22 millimeters sometimes is what you go to. You've got to listen to the patient, and their body will eventually kind of say, I think I need a little more height here. Give it to them. Today alone, I had 2 people, they just said, I think I need more height, but I really don't know. I said, okay, I'll give you a millimeter or 2. And if you need to call us back, hey, we're in town all week. Call us back tomorrow. We'll drop it back down again. But why not try it and see? A lot of this is truly guesswork at the beginning. Then after a while, you get a feel for what the patient needs. If you can do muscle testing, that would surely help a lot. That's where you just ask the patient, and some of you know what I'm talking about. There's also the Dr. Amora ring testing that will help determine the positioning. Again, I don't want to get into that too much, but if you want to look into it some more, and you're all welcome to give me a call, and I'll show you what muscle testing is all about. I've had a lot of fun doing it, and you all could too, but that's a whole other 15, 20 minutes.
What about a stubborn unilateral closed lock? What do you do in those cases?
If it's closed and locked, you may need surgery to release it. Again, though, I've had so many people, they can only open to like 12 millimeters or so. You get the splint in there. Now, at my office, we use the handheld laser, the BioLase, and I have a certified massage therapist as well. Oftentimes, if I just get the splint in there, get the laser warming the tissues, and then Ruth will massage the head, the neck, the skull region. Often they'll be opening to 22 millimeters at the end of half an hour. And then oftentimes that disc will let go and go back in proper position if you give it time. And if not, they need surgery. That's it.
Someone was asking, what lab do you use for these ALF appliances?
I use Orthodent in Toronto because Bill Van Etten up there, he is the owner of the lab and he's certified by Derek Nordstrom to be able to produce the ALF. There are only a couple labs in the country that do this. And luckily, Bill went through all the training and got certified. And I think that's really an important thing. If you ever get into ALF appliances, and I think y'all should, you've got to get certified on using these things. I'm a member of the ALF Academy, and unfortunately, we didn't meet this year. I doubt that we'll meet next year. But if you ever have time to go on ALF Academy, look for it, join up. And if you ever want to get serious about this, I do teaching in my office now and then. Not right now, not this year, probably not next. But eventually, if you really want to learn how this works, I do what I call crash courses, and it really helps the practitioner get a handle on this and fast. So yes, it's available.
I have a question of how is your Galb different from a lower pivot appliance?
Well, it is a lower and it's a pivot. I put a lot of metallic reinforcement into it as well. I have it all, it's all at my office, but if anybody wants a picture of it, I'm glad to send it over to y'all. Just let me know.
And I have someone asking where you're located.
I'm in Falls Church, Virginia, just outside of DC. We are in between DCAA Airport, BWI, and Dulles, like right in the middle of all of those, basically.
This would definitely be a very interesting course to be part of our mini residency that they're putting together these days.
Yeah, I'm glad to help out if y'all want me. I really don't like these virtual things because it's so hard to see what the audience is going through. That's why I like the real hands-on stuff. I miss that aspect. It was really fun doing real lectures because you could walk around the audience, and if somebody didn't get it, you could clearly see they'd be like that, and you stop and you talk to them. But this virtual stuff I have no idea if anybody got anything that I said. So I hope you all got something out of it.
Well, I have thought it has been a very interesting conversation that you've provided us, and the questions have been great that they have given me. There's some that are very similar. You've answered them a couple of times. Some people have asked for your email to be set where people can see it. Maybe we could have JC send it out with the webinar that she's going to send out in a couple of days. It was probably at the beginning of your lecture, wasn't it, on a slide?
I don't really know. I'm sorry. I'm terrible about
JC
that.
said she will include it.
I'm terrible about that. I don't carry business cards with me. And I don't do any of that. We run kind of a busy practice, and I've kind of stopped handing out business cards over the years. You folks will find that if you get into this path, there's such an incredible need for it. Even through COVID, we never shut down more than 24 hours just at the very beginning to come up with our plan, and we've been rocking through it ever since. And now with unfortunately, with the stress of hanging your head over this computer day and night, we're getting a lot of forward head posture. The C-spines are going out of whack on everybody these days. And it's blowing the discs out too. So we're getting busier than ever. And it's sort of unfortunate that we're hunched over these computers now. We go through quite a protocol at my office these days. We counsel patients on nutrition, vitamin D and B, to talk about sleep regulation. My goodness. And then we start talking about physical therapy, osteopathy. We do it in the office. I have a PT in my office every Friday. Eventually, he'll be there Thursdays, and it's worked out really well. Like I said, team approach, you get a lot more done that way, and the people get resolutions so much faster. And I think that's what it's all about. Help them as quick as you can, get them better, higher quality of life.
I agree. Well, we appreciate you giving us this webinar this evening.
Welcome.
Our room is about to close, so we want to thank you for providing this for the American Academy of Craniofacial Pain.
Well, thank you, folks. Thanks for being here. I appreciate it.
We enjoyed it. Thank you again.
Thank you so much, Dr. Brown and Dr. Lauk. We really appreciated it, and we hope we get to see more of you in the future, Dr. Brown. And thank you so much, everyone who attended. You'll get the recording in just a couple of days. Have a wonderful evening.
Thank you all. Bye-bye.